Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about uncommon scaling disorders. Erythema annuli centrifugum. This annular or polycyclic eruption is characterized by waxing and waning patches with a trailing scale that is chronic and recurrent over months and years. For most, it is idiopathic. However, occasionally it has been associated with dermatophyte infections, foods, medications, and rarely malignancy. Treatment is symptomatic with topical steroids. Erythema annuli centrifugum, polycyclic pink patches with a trailing scale. Ichthyosis. The ichthyoses are a heterogeneous group of distinct genodermatoses characterized by generalized scaling seen at birth or shortly thereafter. Genetic mutations resulting in abnormal epidermal cornification cause the dry scaling of the skin. Severity ranges from mild dry skin involvement like in ichthyosis vulgaris due to filaggrin mutation to severe thick plate-like scaling like in lamellar ichthyosis due to transglutaminase 1 decreased or absent activity, to blistering at birth followed by thick horny spine-like scaling prominent in flexures like in epidermolytic ichthyosis seen in keratin 1 and 10 mutations. X-linked ichthyosis is characterized by dirty appearing large brown scales most prominent on the extensor extremities and trunk of males. It is caused by the deletion of the steroid sulfatase gene on the X chromosome and is inherited as a recessive trait. Mothers carrying the gene often have a history of failure to labor to begin or progress. Corneal opacities and cryptorchidism are frequent findings. Acquired ichthyosis begins in adults and is associated with malignancy, example lymphomas, metabolic disease, example hypothyroidism, and drugs, example retinoids. X-linked ichthyosis, dirty brown scaling more prominent on the lower abdomen. Acquired ichthyosis, diffuse fine whitish scaling in a generalized distribution. Look for a systemic association with a lymphoma, metabolic disorder, or medications. Psoriasis. Psoriasis is a group of confusing scaling disorders that is most easily divided into small and large plaque psoriasis. Both groups have fairly well demarcated slightly scaling erythematous to thin patches and thin plaques which are asymptomatic and chronic. Small plaque psoriasis appears very similar to pityriasis rosea but lasts longer than 2 to 3 months and has a benign course. Large plaque psoriasis has an irregularly shaped, well demarcated and sometimes wrinkled appearance which in about 10% of cases evolves into mycosis fungoides. Skin biopsies are non-diagnostic and treatment with UV light is usually successful. Psoriasis, diffuse, slightly scaling, mildly pink, small patches and thin plaques. Pityriasis rubra-pilaris. Pityriasis rubra-pilaris is a chronic idiopathic disorder characterized by scaling, follicular papules, diffuse and confluent yellowish pink, well-demarcated plaques with islands of normal appearing skin and thick scaling palms and soles. It affects all ages and is generally mildly pruritic. Painful fissuring of the palms and soles can cause significant disability. A skin biopsy demonstrates characteristic findings. First-line therapies for adults and children include the interleukin-17 and interleukin-23 inhibitor classes of biologics. Alternative therapies include methotrexate and oral retinoids but are not as effective as the biologics. Pityriasis rubra-pilaris, red, slightly scaling follicular papules and plaques. Pityriasis rubra-pilaris, red, slightly scaling confluent plaques with islands of normal skin. Pityriasis rubra-pilaris, thickened, dusky red, shiny palms. Case. This 50-year-old man was initially seen in a dermatology consultation for generalized red itchy skin of many years duration. 3 skin biopsies were performed which showed an inflammatory infiltrate with some atypical lymphocytes but not in sufficient numbers to diagnose mycosis fungoides or Sézary syndrome. The patient was treated with a topical steroid cream applied to the entire skin surface. At follow-up 2 weeks later, much of the rash had improved, but a sharply demarcated scaling eruption persisted on the buttocks and feet. What would you do now? A potassium hydroxide preparation was negative for fungal elements. A skin biopsy helped make diagnosis and is revealed pathologic changes in lupus erythematosus. Further laboratory testing resulted in normal anti-nuclear antibody, double-stranded DNA, complete blood cell count with a platelet count, urine analysis, and complete metabolic profile. Testing for SSA was positive and SSB was negative. All these tests confirm the diagnosis of cutaneous lupus erythematosus. How would you treat this patient? Sun protection is the first and foremost, even with the patient's questionable history of sun sensitivity. Topical steroids such as triamcinolone cream 0.1% in large volumes may suppress the lupus. The next step would be an antimalarial such as hydroxychloroquine 200 mg twice daily. If these interventions fail, then systemic immunosuppressants are warranted. Okay, this was a short explanation about uncommon scaling disorders. Thank you for your attention.